Excellent.
Okay, respond whenever it is essential, huh? Because I will not know if you are, what I am saying, whether you are able to hear. Okay. Today, as I promised, we will take up traumatology, upper limb, shoulder and elbow. We'll restrict to shoulder and elbow. Hmm? Wrist and hand will take up sometime later. Okay.
Okay, sir.
Okay. We'll start with some anatomy question. Normal orientation of proximal humerus. Retroversion. Oh, my pen is not writing. Just a minute. Kindly excuse me for a minute. Okay, it is working. Okay, right. Okay, is it better now? I guess. Am I audible?
Yes, sir.
Okay. Normal orientation of proximal humerus.
Sir, retroversion.
Yes. How much?
Sir, approximately it's at I think, sir, 20 degrees, sir.
Which are the choices here?
But there is no choice.
Huh?
Choice is 80 and 50, sir.
You are having 80 and 50. So it is around the available choice. Of the available choice is 50, but it is 30 degree. Okay.
Yes,
You know what? Do you understand what is antiversion and retroversion?
yes, sir.
Say for example, you are looking from above with respect to coronal plane. You know the planes. It is sagittal, coronal, and horizontal. Okay, from top. I hope I am able to make you understand. So the humerus, if the head, this is the coronal plane. If it is anterior to that, it is antiversion. It is posterior to that, it is retroversion. So in humerus, it is retroversion of 30 degrees. In hip proximal femur, it is antiversion of 15 degrees. Understand? Please remember that. So it is the angle, the head is posterior as compared to intercondyle plane of the elbow. Okay.
Yes, sir.
This is the embryological or morphological development from quadrupods to bipods. All the monkey to man or apes who are quadrupods. Here, the hip will be in antiversion and shoulder will be in retroversion. Please remember that.
Sir.
So normal anatomy, I will show. Normal anatomy. Please remember this. This is very, very important. Normal radiological anatomy. Before that, we will. So, normal anatomy, you should know regarding lot of things. Okay. So, what is a normal radiological anatomy? This is the glenoid and this is a humerus. This is only one fifth of the humeral head is in contact with the glenoid. One fourth. It is one fourth. Suppose it is compared to only one fourth. If this is one full circle, if you divide, it is only one fourth of that is in contact with the glenoid. Please remember this. Only one fourth of the entire proximal humeral head is in contact with the glenoid. So it is a unstable joint.
Yes, sir.
Unlike hip, it is a very stable joint. Shoulder is unstable joint. That's why it is a most common joint for dislocation. Okay, please remember that. It is compared to a T kept in the golf. I don't know how many have seen the golf or how many are playing. This is called as T. This is a golf ball. Before striking a first golf, this is called as T, and this is a golf ball. See how unstable it is. Even a little bit movement here and there, suddenly it falls off. So this is compared to T golf ball over the T. That is one fourth of the humeral head is in contact with the glenoid. With that, you can understand how unstable it is. So glenoid, again, important thing is one more important thing. What I want to mention about glenoid is it is a flat surface. It is depth is increased by the glenoid labrum. Say for example, this is glenoid looking from front. This much glenoid labrum is there. This, like a saucer, it increases the depth. Please understand this. This is very important for you. This is, I am showing the saucer from side. This is from the end. Okay, so this is actually flat. The depth is increased. The depth is almost increased by 50% by the glenoid labrum. Glenoid labrum is cartilaginous, fibrocartilaginous tissue adherent to the glenoid margin. You please remember this. So almost the depth is increased. 50% of the depth of the glenoid foci is increased by glenoid labrum. Why it is important is, if there is, we will come to that in a recurrent dislocation or whatever, how much glenoid is important for stability of the shoulder, you should remember. Okay, this is again important because there are Bankart lesion and Hill-Sachs lesion. I will come to that. Okay, and
Yes, sir.
one more thing you should know about the shoulder is the rotator cuff. Rotator cuff muscles are easily, isn't it? SSI,
Sits.
SSIT or sits. Sits is also good enough. SIT, yes. Okay, why? This is for a GT. This is for this is anteriorly. All this is anteriorly. That's why I follow SSIT. So from anteriorly, if you come, there is some disturbance from somewhere. Remember this. If you are looking at the shoulder from side, anteriorly is subscapularis, superiorly it is supraspinatus, infraspinatus,
Laterally,
and
teres minor.
yes.
Teres minor.
Hello, come again. Hello. Yes, please talk.
Teres minor laterally.
Somebody, this, see, I have to show you a picture. If you see a sagittal like this, anteriorly it is subscapularis.
Subscapularis.
Superiorly it is supraspinatus. Then comes, you are going from anterior to posterior. This is anterior to posterior. This I am showing you from side. This is a glenoid. You understand? You have taken away the humeral head. There should not be
Yes, sir.
any confusion. This is the acromial arch where you get this impingement syndrome, supraspinatus, infraspinatus, and teres minor.
Teres
There
minor
is no
laterally.
confusion. Yeah. What lateral you are telling?
Externally, sir. मतलब outside.
Yeah, see, I think there is small confusion what you are causing. These are teres minor and teres major. You should differentiate. Okay, teres minor and teres major. How you have to differentiate is this is a bicipital groove where you get a long head of biceps. Understand? You are able to follow my diagram. I
Yes,
am
sir.
poor at it, but I'm trying. Okay. So pectoralis major attaches to lateral. This you should remember, lady between two majors. Laterally pectoralis major, medially teres major. Hello?
Yes, sir.
Is there any confusion? This is in a bicipital groove, the lateral lip and the medial lip. Okay?
Okay, sir.
We are talking about rotator cuff. All these together, all these muscles together, we call it as rotator cuff. There should not be any doubt here. Subscapularis is anteriorly, from superiorly if you go posteriorly, it is supraspinatus, infraspinatus and teres minor. So you call it as SSIT. That's why I remember is SSIT, or you said SITS, whatever. SITS is subscapularis is anteriorly, SIT is from above posterior. Understand?
Okay,
Some
sir.
disturbance somewhere. Okay, this is about rotator cuff. And one more thing you should remember, uh, this glenoid I will draw again. There is a supraglenoid tubercle where a long head of biceps takes origin. This is glenoid labrum. Here, long head of triceps. This is glenoid labrum. Okay?
Yes, sir.
Long head of biceps and long head of triceps. This is anterior, this is posterior. I will come to Bankart lesions and other things little later. Okay, plus you remember this anatomy. So what you should see in a X-ray, it's very easy, isn't it? This is a normal AP view. This is scapular Y lateral view. You have to remember one view which is called as scapular Y lateral view, wherein this is a lateral view. This is a lateral view. This is normal shoulder AP view. Look at the first picture. Anybody can easily diagnose, isn't it? What is the first picture showing you?
Sir,
First picture.
dislocation, sir.
It is dislocation. It is dislocation. We don't know whether it is anterior or posterior. You are an inexperienced intern working in casualty. You see the humeral head is not in the glenoid fossa. It has dislocated. But because it is only AP view, you don't know whether it is anterior or posterior. Understand? So for
Yes.
that, what we do, we have to do scapular bilateral. See why it is called scapular bilateral is, look at the diagram of the scapula here. Look at this. It is looking like a Y, isn't it? You have to take a Y, lateral view where the scapula looks like uh, Y. So what is this? This is coronoid process. This is acromial process. So where is our head now? Head is anterior or posterior?
The posterior, sir.
No, this is coronoid process. I'm telling you, this is coronoid process. Look at this head. Look at this head. This is our glenoid fossa. Your head should have been here. It has come anteriorly. Am I clear? See, this is your glenoid fossa. This is your coronoid, and this is your acromion. Why? That's why you are looking like a Y now. This is called as scapular bilateral. This is humeral head. So where is your humeral head gone? It has gone anterior. This is coronoid. Please remember this. This is not so important, but scapular bilateral is important to look for anterior or posterior. But that is not always necessary. In casualty, whenever you see AP view, it is very, very easy. This is a anterior dislocation of the shoulder. Again, there are three types. One is pre-glenoid. It is in front of the glenoid. It is pre-glenoid. It is below the coracoid. It is infra coracoid, or it is below the clavicle, it is infraclavicle. So there are three types of anterior dislocation. How much it is migrating medially, please remember that. So one is preglenoid, second infracoracoid, third infraclavicular. Okay, depending upon how much it has migrated medially. Right. So look at the other picture now. This is important. Look at these two pictures. Which one is normal in this? This is picture A, this is picture B.
B, sir.
Which is normal?
B, sir.
Huh?
B.
Which
B,
one
sir.
is normal? Anybody else
B.
want to differ? All are agreeing it is B?
Yes, sir.
Yes. See, this is a normal shoulder X-ray. You can see a joint space here. It is normal proximal humeral head. What has happened here? The shoulder proximal humerus is looking like this. What is this? The proximal humerus has, it appears it is completely internally rotated. This is one classical sign. It might appear as an image based question for you tomorrow. It is no doubt. There is a emptying of the glenoid. Shoulder has completely internally rotated.
Yes, sir.
This is classical light bulb sign. Classical looks like a light bulb, isn't it? You are not, nowadays you are generation of LED bulbs. So now whatever you are seeing, there was a bulb which were looking like this, isn't it?
Yes,
This
sir.
is a classical light bulb sign. Compare these, please remember these two pictures very, very clearly in your mind. This looks like a light bulb. This is not a light bulb. So light bulb sign is classical radiological hallmark for posterior dislocation of shoulder. Most common in epilepsy. Following epilepsy, you get to know. We'll come to the details of posterior dislocation little later. Okay, this I will show you some radiological and images what I wanted to show. You are seeing the shoulder from above. So whenever the shoulder has dislocated anteriorly, this is posteriorly, this is the glenoid rim. This is what I was mentioning. This is the fibrocartilage or a glenoid labrum. So when the shoulder is dislocated anteriorly, the part of the head goes and hitches on the anterior part of the glenoid. So in the bargain or in the milli, you will see there is a rupture of the glenoid labrum and there is a impression fracture. It is like a wet clay. If you put a thumb in the wet clay, you make an impression, isn't it? You might have played with the clay. Your wet clay, if you put a thumb in that, make an impression. Similar to that, there is an impression on the humeral head. So these are essential lesions. So there is a rupture of the capsulolabral complex. So anterior labral complex is ruptured. It is Bankard's lesion. Bankard's lesion. And there is an impression. Where is this? This is your glenoid, this is your bicipital groove, isn't it? Which is anterior. This is posterior. So posterolateral aspect of the humeral head, there is a crater or a deep impression or an impression fracture. That is called as Hill-Sachs lesion. Okay, that's very, very important. It looks like a crater named by Hill-Sachs. It is Hill-Sachs lesion. Please remember this. We have some questions based on these lesions. We'll come to that. But if you understand this, it is very easy for you people to understand the anatomy. Okay. So this is one more thing what I wanted to highlight about the glenoid. This we are looking at the glenoid. This is the glenoid. This is your glenoid labrum. This is your occipital long head of bicep. Okay. So this is anterior coronoid process. Anterior. This is acromion process. Posterior. You hold a scapula if you are having some time later, then you will get oriented easily. So if you divide this superior, inferior, anterior, posterior. So antero-inferior part of the glenoid is avulsed from the margin. This is the avulsion of glenoid labrum from anterior inferior portion. So this is called as Bankard's lesion. There's one more important thing you please remember. These are labeled very well, isn't it? Glenoid and this is labrum. One part which is avulsed. It is like what to say. You have there is a cuff. Your arm sleeve is torn. Arm sleeve is torn in one portion. It is like that. Okay. It is arm sleeve. You are wearing a sleeve, isn't it? If it is torn in one portion, it is like that. It is a Bankard lesion. But sometimes what happens, there is a part of the bone also which goes away in the anterior dislocation. It is called as bony Bankards. Bony Bankards. It might appear in future. So far, I have not come across any such questions. But please remember, bony Bankards also can be there. Bankard lesion is avulsion of anterior-inferior portion of labral complex, labral capsular complex. Okay, some questions. So Bankard lesion is seen in no-brainer, quick.
Sir, recurrent anterior dislocation.
Very good. Recurrent, please remember, recurrent dislocation. Anterior dislocation you will get, but you will reduce in acute anterior dislocation. You will reduce. The patient heals well. There need not be Hill-Sachs lesion. There need not be a Bankard's lesion. But if the shoulder joint repeatedly dislocates, so most common lesion is Bankart's lesion. Why Bankart's lesion is essential? As I said, it increases the depth of the glenoid. So once it is avulsed here, so the depth is reduced, isn't it? So that is the cause for a recurrent dislocation. So the treatment for that is, there is arthroscopically whatever you do. Whole idea is, I'll go back to this picture. Whole idea is you have to repair this. You have to put the stitches, or you have to put a screws. Nowadays you have got anchors, suture anchors. It is very difficult. The picture, even though it appears so nice here, it is very difficult to repair. Go in and repair. So what they do, they put anchors. Anchors, you know, no?
Yes, sir.
Anchors used in ship anchoring. So it will be like this. So what happens? You put one anchor here, you put one anchor here, you put one anchor here. There are sutures for this. There are suture thread. So what you do? You put a knot here, you put a knot here. So this is repair of the Bankart lesion. More commonly, best is done arthroscopically, but not everybody is trained or facilities are not available. It can be done open Bankart repair also. Bankart repair is again one of the treatment for recurrent anterior dislocation. Okay, posterolateral lesion of the head of the humerus in case of recurrent dislocation of the shoulder. Yes,
Hill-Sachs,
quick.
Hill-Sachs.
Hill-Sachs lesion. Okay, reverse Hill-Sachs lesion, please remember, is seen in posterior dislocation, recurrent posterior dislocation, which is very rare. Please don't get confused. It is not essential, but if you can remember, it is very good. Reverse Hill-Sachs lesion in Hill-Sachs in recurrent anterior, recurrent posterior is reverse Hill-Sachs. Okay. 42 year old man diagnosed to have irreparable rotator cuff. Irreparable rotator cuff tear. Very important. Please remember this. Treatment of choice. I'll come to that later.
Tendon transfer, sir.
Yes. Okay. Patient is young. Patient is young. So these two options are there.
Above 60, sir.
Above 60. Very good, Roshan. Above 60, these options are there. But again, there is a difference when to do total shoulder, when to do reverse shoulder. I will explain that later. Acromioplasty. Remember, acromioplasty is, again, I will draw a diagram here. There is a coracoid here. There is a acromion, right? So there is this is your supraspinatus. Okay. So when you do abduction, there is a pain. There is a initial abduction, rotator cuff arc syndrome, painful arc syndrome. You remember this? I think you must be knowing. I will briefly touch upon this. Painful arc syndrome is, it is painless, painful, and painless. So throughout the abduction, initially it is painless. This entire arc, when you do abduction, painless, painful in this entire range, and above that it is painless. So this rotator supraspinatus, there is a very small space, isn't it? Whenever you start abducting, the space is narrowed, it gets impinged. In that case, you do remove part of the acromion, subacromial surface acromion. If you remove, that is called as acromioplasty. So acromioplasty, just as a passing mention, I am trying to tell you that it is essential in times of treatment of impingement syndrome or rotator cuff supraspinatus tendinitis, wherein you just shave off this one, you make a wider portion. So that is in impingement syndrome. So I wanted to show you these two pictures. Roshan, you mentioned, isn't it? So
Yes, sir.
Just remember, this is total shoulder arthroplasty. This is reverse shoulder, reverse total shoulder. You please remember this picture very nicely. It is easy. What is this is normal humeral head, glenoid fossa. This is normal total shoulder replacement. Here what has happened? Head is becoming cup and your glenoid has become head. So this is reverse total shoulder arthroplasty. This is normal total shoulder arthroplasty. Whatever I write on the screen, is it visible?
Yes, sir.
Okay, good. So there is very important thing. Only one line I will tell you. You have to remember this. When you do total shoulder, when you do reverse total shoulder arthroplasty. So for total shoulder, your supraspinatus has to be normal. You know what? This supraspinatus is main function of the supraspinatus muscle is it is initiation of the abduction and depresses or holds the position of the humeral head. So if this is functional, you do total shoulder arthroplasty. But if the supraspinatus, there is a tear, irreparable rupture, which has gone for a already shoulder arthritis, that time you have to do reverse total shoulder arthroplasty. Just remember this. I will not go into detail. This is not at this level. So Bankart lesion involves read.
Anterior inferior.
Antero-inferior lip of the glenoid labrum. Okay, good. So lift-off test is done for
Sir, lift up test is supra supra suprascapulary, sir.
you are telling a muscle which is not existing.
Subs.
Sorry, subscapulary, sir.
Very good. This is for subscapularis. I'll show you one diagram about that, then you will know. See, this is your lift-off test. This will assess the strength of the subscapularis. You ask the patient to position his arm like this, and the doctor presses the palm and he tries to lift off the back. This tests the strength of the subscapularis. Okay, this is one picture I wanted to so that you'll remember. Okay, 1 minute. I'll go. Okay, rotator interval is between. You can answer this.
Sir, rotator interval supraspinatus and subscapulary, sir.
Very good. Very good. This is rotator cuff interval. There is lot of importance for this. As I was mentioning, again, I will draw the glenoid labrum. This is subscapularis. There is SSIT. No, sorry. Okay. This is SSIT. So the interval here is rotator cuff interval. Rotator interval. Here one important coracohumeral ligament. If you can memorize also, you please you memorize this. Coracohumeral ligament passes through this interval. So what is coracohumeral? It attaches from coracoid to the humeral head. It is very easy. It's self-explanatory. But you remember, it is a coracohumeral ligament. It is placed in a rotator cuff interval. Okay, this is important. There are again a lot of other ligaments. I didn't go much into that. Okay, but this was only relevant for this MCQ. Okay, this diagram, if you can remember, it will be very good, right? So this is supraspinatus. You can see this very well. Okay.
Yes, sir.
This is a swollen one. I was mentioning about acromioplasty. If you shave off this much, not the ligament, not the coracoacromial ligament. There is a partial ligament removal and under surface of the acromion removed if this is swollen. ಹಾ 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 ಬರ್ತೀನಿ ಅರ್ಧ ತಾಸು. ಹಾ ಅವ್ರಿಗೆ ಹೇಳಿನಿ. ಯಾರ ಹೆಸರೇನು ಬಸಮ್ಮ? ಹಾ ಬರ್ತೀನಿ ಅಂತ ಒಂದು ಡೈಕ್ಲೋಫಿನಾಕ್ ಮಾಡಿ. So this diagram is important for one thing. When the rotator supraspinatus is swollen, there is less space and abduction, painful arc syndrome, and all that. That time, if conservative treatment doesn't go well, you will not get into that. Okay. This I was coming here for two reasons. This is your subscapularis. This is your supraspinatus. The interval here is rotator cuff interval. Cocker maneuver is used for quick. You will be knowing this. I will not touch much into that. Cocker maneuver is used for. These are all dislocation only.
Forgets.
Cocker maneuver is used for anterior shoulder dislocation.
Okay, sir.
Okay. We'll come to this one more important thing. One more thing what I wanted to mention about is we'll stay here for a while. So in anterior dislocation of the shoulder, there are few tests if you can remember. B, D, C, H. These are there in most of the triangles.
Dugas test, Byron.
Yes, Dugas.
Byron Calways.
Very good. And Hamilton ruler test. These are the tests to be performed in a case suspected to be a anterior dislocation of the shoulder. Okay. I will explain to you one by one. Maybe I have some diagrams for that. I will come to that later. But please remember this. So most common sequelae of traumatic shoulder dislocation. Yes. Anybody can take this. This is very interesting MCQ what I found in the textbook. It is very, very applied orthopedics. You will remember this for a while.
Sir, recurrent dislocation, sir.
Very good. So recurrent dislocation is the most common complication of traumatic shoulder dislocation in young adults. Shoulder dislocation, what is false? Quick. Read the choices very carefully. There is nothing very complicated in this. Yes. Yes, Roshan. What is the confusion now? Have you narrowed down the choices of the four choices? Is there two choices you have ruled out? That's how you generally answer when you are in doubt, isn't it?
Yes, sir.
So what are the choices you have ruled out now? Shoulder dislocation, what is false?
Sir, ruled out is rotator cuff injury is common cause of recurrent dislocation.
Your answer. What are you doing now?
It's Rule out, sir. It's correct.
Yes, it is the answer. This is the answer. Hill-Sachs lesion, you know, it is one of the bony lesion in recurrent anterior dislocation. Common complication early is there is a axillary nerve
Axillary.
neuroplasia. What is
Yes,
that
sir.
sign called as? Anybody remembers?
Uh,
Anybody remembers that? Regiment badge sign. Regiment badge sign. You know why it is called as a regiment badge sign? The nerve supply or a paresthesia. There is a paresthesia. Say I can't draw. Policeman wears a sleeve and he wears a badge here, isn't it? There's a badge on the side of the sleeve. So the paresthesia is in that area, lower 1/3 of the deltoid insertion. There you get the paresthesia, exactly where your badge or a name, not a nameplate, the badge of a police officer or army officer comes on the side of the sleeve, isn't it? Regiment badge sign. There is a paresthesia there. Okay.
okay, sir.
And posterior dislocation presents with difficulty in external rotation. It is a no-brainer. So the shoulder, the humerus is locked in a internal rotation. You cannot do a external rotation. Okay. So all are seen in anterior dislocation. This is what I wanted to come to you.
Hmm. Sir, it's
Yes.
accept, sir.
Huh?
Questions are accept.
Accept. Yes, accept.
Sir, increase vertical conference.
No. Dugas test, yes. Hamilton ruler test, yes.
Yes,
Increased
sir.
vertical conference, it is, there is a typo here. It is a circumference. Okay, there is a typo error. Increased vertical circumference is found in dislocation. Anterior axillary fold is not elevated. It is lower. I'll show you a diagram for that. You'll remember. Okay, this is what I was wanting to show. So what is Dugas test? If there is a dislocation, the patient cannot touch the opposite shoulder. So this is the Hamilton ruler test. See here, this is a ruler which is kept on the lateral epicondyl of the humerus. It doesn't touch the acromion because of the deltoid contour. But if it is dislocated, see, the ruler is touching the lateral acromion process and the lateral epicondyle. This is a Hamilton ruler test. Look at the difference here.
In normal
So,
person, it would not be possible, sir.
yes, you can see, no, there is a gap here.
There's a gap.
In dislocated shoulder, see, the ruler touches from end to end because there is a loss of a deltoid contour. Okay. Yes, this was what I was mentioning. This is Callaway. Callaway is what?
Yeah,
Callaway
comparison of
conference.
dislocated shoulder with another.
Yes, loud, loud, loud. I want
So
to hear.
it is the comparison of the dislocated shoulder with the normal side to see the
Very
circumference.
This is again showing you a Hamilton ruler. What I wanted to show you here is this, if it is head has come here, this vertical circumference you measure, you take a tape and in the axilla and measure from end to end. Put your tape in the axilla of the arm and measure from at the acromion process. This is called as vertical circumference, which will be increased in anterior dislocation of the shoulder. This is one picture which not given in many of the textbook. Vertical circumference of the axilla is what is measured by this. Can you see this? This
Yes,
tape
sir.
going from anterior to posterior, measuring the vertical circumference of the axilla. That is a Callaway. Okay, it is increased in anterior dislocation of the shoulder. Yeah, this is what I was telling. In recurrent dislocation of the shoulder, the movement that causes the dislocation. So, there is a recurrent dislocation of the shoulder. What movement causes the recurrence? He will be normal. The patient will be normal. In what movement suddenly it keeps dislocating? Very easy. Very easy.
Sir,
No.
Very, very easy.
abduction and external rotation.
Good. Abduction and external rotation. There's nothing much to discuss, isn't it? So,
Yes, sir.
shoulder has to go anterior means external rotate. Abduction, external rotation, it causes the recurrent dislocation. I mean, a patient is having a recurrent dislocation. He tries to throw a ball or do overhead activities in abduction, external rotation. Suddenly, it gets dislocated. That's also called as an apprehension test or apprehension sign. You stand behind the patient, you try to abduct the shoulder and slowly external rotate. Suddenly the patient takes away his arm because he feels that the shoulder is going to dislocate. Following anterior dislocation of the shoulder, patient develops weakness of the flexor of the elbow, loss of sensation of the lateral aspect of the forearm, which is the nerve which is likely to be injured. Very easy if you remember.
Flex. Sir, ulnar nerve.
No. Ulnar, see, I think I remember in my UG days, ulnar nerve is a musician's nerve. Median nerve is a laborer's nerve.
Laborer's nerve.
This is we taught. Ulnar nerve supplies mainly the intrinsics of the hand. Mainly supplies intrinsics of the hand, intrinsic muscles. About 20. There are.
Axillary nerve, sir.
No.
Radial nerve,
Axillary
sir.
nerve may.
Radial nerve.
The only thing remaining is musculocutaneous. Radial nerve, wrist drop. Axillary nerve, only deltoid. Ulnar nerve is supplies. There are 20 muscles in the hand, 4 muscles into 5 groups. Okay? So
Okay, sir.
15 are supplied by ulnar nerve, 5 are supplied by median nerve. This I'll come to when I take hand topic. But please remember, it is musculocutaneous nerve. See, is given very nicely. Weakness of flexors of the elbow. Sensation on lateral. It supplies what? Coracobrachialis and you go and read. This is the answer. Luxatio erecta is what? Luxatio erecta. This is the 4th choice.
Okay, sir.
Yes, tell me. It is easy. When you read the heading, it is self-explanatory. Go through the choices. Even if you do not know the answer, you will be easily, by ruling out, you'll come to the correct answer.
Sir, it's I think, sir.
Yes, try.
Sir, inferior dislocation.
Very good. It is the inferior dislocation. See, luxatio is a Greek word, I guess. I don't know. Subluxation is something less than luxatio is dislocation. Erecta is what? Straight. It comes exactly below the glenoid. Luxatio erecta. But the shoulder will be in abduction. Luxatio erecta is inferior dislocation of the humeral head. It is inferior to the glenoid. It is in a straight line. It is erecta. Erecta is what? Straight. It is in straight line. It is inferior to the glenoid. Inferior dislocation. It is seen in whenever patient falls from a height and tries to catch a branch or whatever is hanging. Suddenly the head comes inferior to the glenoid because of the hyperabduction. The limb is always kept in hyperabduction over his head. But the head is inferior to the glenoid. It is not that head, the arm is straight. Arm is abducted, but the head is inferior to the glenoid. Okay, am I clear?
Yes, sir.
Light bulb sign, as I said, very easy. We'll quickly rush through now. Light bulb sign I had explained, isn't it?
Yes, sir. Yes, sir. This is posterior dislocation, sir.
Very good, very good. So which is true regarding posterior dislocation?
Uh, all of the above, sir.
Very good. All of the above. See, most commonly, remember, posterior dislocation is seen in a patient with convulsions.
Electric shock.
Whenever there are he will go for adduction and internal rotation of the shoulder. Severe convulsion, the patient is unconscious. He will not know that whether the shoulder is dislocated. Pain is severe in anterior dislocation as compared to posterior. Posterior is less painful and it is often overlooked because in anterior dislocation patient comes with holding his arm. In dislocation, the patient will come with pain. He will go to different doctors. They will take X-ray. They do not detect a light bulb sign. They say it is normal. The patient will be keep on moving. There will be some movement because the scapula moves. Okay, this is very, very important about posterior dislocation of the shoulder. 16-year-old boy with recurrent anterior dislocation. He is examined supine bed on the bed. Doctor abducts 90-degree, externally rotates with the bed as a fulcrum, but the boy resists. The test is very simple, isn't it? Instead, I would ask what is this, mention this test and ask what it is.
Sir.
This is what I did mention during explanation.
Sir, anterior instability test. That is.
Yes.
Apprehension.
Which among the tests now here?
Apprehension test, sir.
Very good. Apprehension test. Sulcus test again. I will mention here because in some other slide it might appear or it might not appear. You pull the shoulder when the patient is standing erect. There is a sulcus created just below the acromion. It indicates there is a hyperlaxity of the shoulder.
This is the inferior instability, sir.
Inferior instability, which is uncommon, it is hyperlaxity of the shoulder. We'll come to something called as tubbs and ambry. If you have read, you will remember. Okay, tubbs is traumatic unidirectional Bankard's surgery. This is how you should remember. Traumatic anterior dislocation. Unidirectional is always in anterior. Bankard's is always an essential lesion. The treatment is surgery. Ambry is atraumatic. Rehabilitation is the treatment. You do not do the surgery here. And I will come to that. Okay. Bilateral. This is unilateral and unidirectional. One shoulder. The ambry can be in bilateral. Atraumatic, bilateral rehabilitation. Inferior capsular shift procedure is done occasionally. internal closure. All you don't remember all that. Just remember tubs and ambry. You will somewhere these mnemonics will help you in answering few questions. Anything beyond that is not for your level. So what happens? Should we proceed? We are about to close for. Okay, it is 9 o'clock. One more important thing I will mention. We'll finish the dislocations only. I will not go to the clavicle. So the surgery for recurrent anterior dislocations are Bankard's procedure, Putty's procedure. Okay, Bankard's procedure, Putty's procedure. I will explain you one by one what is that.
Yes, sir.
And there is called as latter jet Bristow's procedure. This also appears in some MCQs. I will explain you these three procedure and then we'll close. Okay. Bankard's procedure, as I said, there is a avulsion of the glenoid labrum. You put suture anchors or repair, and that is Bankard's. So in Putty Platt's procedure is there is a glenoid, there is a head here, and there is a subscapularis here anteriorly, isn't it? This is anteriorly. So when our shoulder dislocates, whenever you externally rotate and abduct, okay. So what they do, they will cut this subscapularis and shorten it. They overlap. Say for example, they cut this and they overlap like this. Double breasting. This is called as double breasting. They cut and overlap the subscapularis. So by that, what they do, the external rotation is not possible. So that's why the dislocation is not possible. This is Putty Platt's procedure, but please remember this is not done anymore. This is more of a historical importance. Most commonly preferred currently the procedure what is done is Bankard's repair. One more thing is was Bristow's or latter J. Latter J procedure is there is a coracoid here, isn't it? So coracoid gives origin of what? Coracobrachialis, tip of the coracoid. I will not go into the anatomy. I will. What are the muscles attached to the coracoid process? If anybody can tell me quickly, I'll be happy. But I will restrict myself to tip of the coracoid process, which gives origin to two muscles. One is coracobrachialis, another
Yes, sir.
is short head of the biceps. Long head of biceps originates from here, isn't it? Short head of the biceps originates from the tip of the coracoid process. Short head and coracobrachialis. So what they do, they cut this coracoid tip with the muscles and bring and attach antero-inferiorly. They cut the tip of the coracoid process and attach this to antero-inferior part of the glenoid with a screw. This is latter J procedure. Okay, Bankard's, Putty Platt's, and latter J procedure. Okay.
Okay, sir.
Okay. With that, I will come to end of today's class.